Welcome back. Now we talk about third lecture in the series of recent update in 19th edition and the recent update in medicine. So now this is lecture number 3. Lecture number 3. In this we see what recently things have come in the hematology or in the blood. There have been many new antiplatelet drugs and anti-clotting drugs have come up, but we will never understand them unless we know the basic concept how the platelet plug formation occurs. Then I can give you a better answer to what drugs we are using. So first we talk about pathophysiology of platelet plug formation. Platelet, which I will be writing as P, plug formation. Platelet plug formation. Okay, let's talk about platelet plug formation. Basic concept. So first we learn the basic concepts. This you should know. Basic concepts. Here the injured endothelium. Injured endothelium. Okay. Here the platelet, and they get attached to injured endothelium via von Willebrand factor. This is the platelet P. And these are attached here via GP1A/9 receptor. Zoom करेंगे. GP1A/9 receptor. Now they are attached. These two platelets are attached to each other via fibrin, and they is attached via GP2B3A receptor. Got it? This is the basic how the platelet plug formation occurs. It means what? To have a platelet plug, there should be injured endothelium should be there. That's why this platelet plug does not occur in a normal blood vessel. Got it? Now the other thing what needed is platelet, von Willebrand factor, fibrin, GP1A, GP2B receptors are needed. So wherever any problem will happen, there will be defective platelet plug formation. So now defective platelet plug formation will occur in following condition. Number 1, so defective platelet plug formation. Defective platelet plug formation. Defective platelet plug formation. And remember, whenever the defective platelet plug formation will occur, bleeding time will be prolonged. So number 1, reduce platelet count, so-called thrombocytopenia, classically occurs in ITP. Number 2, reduce von Willebrand factor in von Willebrand disease. Third, reduce fibrin level in DIC. Fourth, defective GP1A/9 receptor. This occurs in Bernard Solier disease. And fifth, defective GP2B3A receptor. That occurs in Glanzmann's thrombasthenia. This is the box number 1. This is the box number 1 in this lecture. So, reduced platelet, reduced von Willebrand, decreased fibrin, defective GP1A receptor, and defective GP2B3A receptors. Based on this basic fundamentals, let's see what new drugs have come up. So first of all, we talk about the new drug in ITP. New drugs in ITP, the treatment of ITP. Drugs. The first drug is romiflostin. Romiflostin. It is given subcutaneous. Second is L-Trombopac. L-Trombopac. It's a tablet. Both these drugs are thrombopoietin receptor agonists. Both these drugs are thrombopoietin receptor agonists. They are the latest drugs, the treatment of ITP. Point note, this is a tablet, this is subcutaneous. Then we got rituximab. Rituximab, and we discussed earlier, is a new anti-CD20 drug we use in the treatment of ITP also. But we got one more new drug which is not given, which is again recent advances we have come up. That is Oprelvicin. It's a new drug for treatment of ITP. This is the box number 4. So we got new drug 1, 2, 3 and 4 new drugs in the treatment of ITP. Now we talk more about more antiplatelet drugs. More antiplatelet drug, new drug, recent advances. The newer antiplatelet drug, obviously, whichever antiplatelet drug we are using, they will cause prolonged bleeding time if you use the new. We have been using aspirin, no need to discuss. Now newer antiplatelet drug. The new drug, which category is? First category is P2Y2 antagonist. P2Y12 antagonist. Y12 antagonist. P2 Y12 antagonists. They are antiplatelet drugs. Antiplatelet drugs. They include cangrelor, ticagrelor. Cangrelor, ticagrelor. This is the box number 5. Now this drug is being widely used in coronary artery disease also. So P2Y2 antagonist, antiplatelet drug, cangrelor and ticagrelor are the drugs that we talk about. Then we have PAR1 antagonist, again antiplatelet, PAR1 antagonist. They are again antiplatelet drugs. Antiplatelet drugs. They are vorapexar, etopeXAR. Vorapexar, etopeXAR. This is the box number 6. New drugs. PAR1 antagonists. They are all antiplatelet drugs. Okay. Well, we have been using, now we talk about anti-clotting drug. We have been using heparin for a long time. For last 5-6 decades we have been using. It's a cheap drug, easily available, is heparin. But heparin has got some major side effects. The side effects of heparin. They are, it can lead to osteoporosis, it can lead to hyperkalemia, and it can lead to heparin induced thrombocytopenia. Heparin induced thrombocytopenia. It looks that it reduces platelet count. It means there should be more bleeding, but surprisingly it tends to have more clot formation. So due to HIT, patient has tendency, because of autoimmune phenomena, patient has more tendency to make more clots. So they were looking for the newer drugs. Now let's talk about newer anti-clotting drugs. Newer anti-clotting drugs. Newer anti-clotting drugs. Anti-clotting drugs. We have a low molecular weight heparin. We have pentasaccharide. We have direct thrombin inhibitor. Direct thrombin inhibitor. So first of all we talk about mechanism of action. It inhibits factor 10A and thrombin. Examples: this is enoxaparin, delta pairin, tenzapairin. Pentasaccharide, they include, it inhibit factor 10A. They example are fondaparinux, idraparinux, then we have a direct thrombin inhibitor. They inhibit thrombin. They inhibit thrombin. Example are dabigatran, zymalgatran, dabigatran, zymalgatran, lepridine, bivalirudine, okay, zymalgatran, dabigatran, lepridine, bivalirudine. Now zoom out करेंगे. I hope you have written. Yeah, zoom out. Now if we look at this table, it looks very dangerous table. Let me simplify this table for you. Now look at this thing. First of all, we have three categories: low molecular weight heparin, pentasaccharide, and direct thrombin inhibitor. So first of all, we see what is the mechanism of action. Direct thrombin inhibitor inhibit thrombin, easy to remember. This is penta 10A. Penta 10, easy. Penta 10, easy. And low molecular weight, this is both. So we can sing a song. Thrombin 10 both. Very simple mechanism of action. Thrombin 10 both. Now the names are real very difficult. Let's see how I can simplify. This is low molecular weight heparin. This is enoxaparin, delta parin, tinzaparin. All parins are here. Okay. This is penta, fondaparinux, idraparinux, simple, and they are dabigatran, zymalgatran, the two gatran, and the lepridine and bivalirudine. Okay, so friends, this is parin, panax, gatran, and ridine. So very simple to revise. How can you revise? Thrombin 10 both, parin, panax, gatran, ridine. Okay, parin, parinax, gatran, ridine. So simple. So thrombin 10 both, parin, panax, gatran, ridine is a simplified what I can talk to you. Well, there's few more drugs have come up. So now, out of all these friends, you may forget every damn thing, but you should not forget this drug. This is a tablet, and widely used in clinical practice actually. So you should never forget this drug. You should never forget this drug. Okay. Now there are two new drugs have come. Factor 10A inhibitor. 10A inhibitor, new drugs. The new drug in factor 10A inhibitor are rivaroxaban, apixaban, and rivaroxaban. Make a box. So friends, from the new drugs what I gave to you, you will definitely get some new question. And remember, as I was talking to you regarding prometric system, all recent advances are of higher category number 4 or 5, because in routine guides what you have been reading, you will not get all these things at all. But examiner want to know whether you know the latest advances or not. And if you happen to read my medicine essence book, that contains at least 95% of the material what I taught to you in the last lecture and this lecture also. So we'll be talking more in the next lectures regarding other branches. So stay tuned and look for the lecture number 4, 5 and onward to come very soon. Thank you very much.